I'm an emergency medicine physician. I work in a level 1 trauma center, comprehensive stroke center. We see about 115,000 visits a year at my shop. So it's a busy place. We see about 26,000, 27,000 ambulance runs every year. So American College of Chest Physicians recently came out with their 2018 guidelines as recently as about a couple of weeks ago, and they provide us with some guidelines, some suggestions. Of course, we as independent physicians have the ability to think independently and do what we think is best. But they offer some reasonable guidelines. I think if someone has a major bleed, it's one thing, and if they have a minor bleed, it's something else. For minor bleeding, if they're on a DOAC, say delay the dose. If they're on a vitamin K antagonist, obviously we would withhold until their INR is below 2. Moderate bleeding, they give us some interesting recommendations. Delay or discontinue the agent. Maintain diuresis and volume support. And why is that important? Remember, all of these agents, to some extent, have some portion of renal elimination, and they vary across the spectrum. If we look at the one that's most heavily relied upon on renal excretion, it's actually a direct thrombin inhibitor. It's Pradaxa. It's about 80% eliminated in the kidneys. And as we go down the line, Severity is about 50%. That's Anticoagulant. Then Rivaroxaban, Xarelto, is about 36%. Apixaban, or Eliquis, is about 27%. And then Apixaban, a newer one that's indicated for medical prophylaxis in the medically ill patient population, is only about 11% relied upon for renal elimination. So it's across the entire spectrum. So maintaining volume diuresis is important in these patients to help eliminate it. Obviously, mechanical compression is important. Transfusions, if you got a trauma patient, a 1-to-1-to-1 transfusion is ideally what we're doing on a trauma basis. Vitamin K antagonist, consider adding vitamin K, 10 milligrams IV, and with a DOAC, I'm not sure I agree with this. What are your guys' thoughts? Consider absorption activated charcoal if the last dose was within 2 to 4 hours. I can't tell you the last time I used charcoal. How about you?
Maybe once a couple years ago when the person took their overdose within 15 to 20 minutes, like in the parking lot. Other than that, no.
So the 2 to 4 hours is also important. I know we have some pharmacists in the room, but 2 to 4 hours is actually important. And the timing of the last DOAC dose is something that we want to know as we're managing these bleeds. And the reason for that is all of these novel oral anticoagulants, not really novel anymore, they're DOACs, have a fairly rapid onset of action. Most of them are reaching peak concentrations within 2 hours of taking the pill. So your greatest tendency to bleed is within about 2 to 4 hours after taking one of these DOACs. And obviously for the serious life-threatening bleeds, supportive measures, and then here's where it gets really good. Reversal is critical. Yesterday I heard a talk and they said reversal equals resuscitation. There were some misconceptions that were provided, but reversal equals resuscitations. With vitamin K antagonist, PCC is your drug of choice. With the anti-10As, we now have a reversal agent. And most of the major societies, including CHEST and some of the other ones, are recommending an agent-specific reversal when it's available. PCC when it's not. So, Colin, what's your impressions of the CHEST guidelines, and are you aware of other guidelines that might suggest reversal?
There's a lot of guidelines out there that are now American Heart Association, European Society of Cardiology, American Society of Hematology.
Our own organization is actually coming out with its recommendations that'll be comparable to ACC's, and colleagues of mine that are involved in writing the ACEP's recommendations say that it should be out fairly shortly as well.
The only comment that I have about the guidelines is, again, giving the reversal agent when the person has an extremely time-sensitive problem is important. But remember, when something gets into a guideline, you just have to be careful that that guideline doesn't supersede good clinical judgment. Because there are times when waiting to find out might be useful, or waiting to see what intervention you're going to get might be useful. But in general, I think they're very important and something everyone should have a chance to read.
So Colin showed this, and here's our coagulation cascade. We know where dabigatran, Rivaroxaban, Apixaban, Andoxaban, Apixaban, and all these agents work. And if I'm going to give a reversal agent, the 4-factor PCCs are obviously replenishing the factors that warfarin tends to destroy. So 4-factor PCC would be beneficial if you're poisoning factors 2, 7, 9, and 10. 3-factor PCC is basically 2, 9, and 10 with not that much factor 7 involved. If I need to reverse factor 10A inhibitors, Andexxa is the reversal agent for 10A inhibitors. If I need a direct thrombin inhibitor reversal, it's Apixaban. And that's basically our reversal agents for these anti-10As. So this is an interesting question. I like the title, the agent formerly known as Prince. What do we call Andexxa? If you guys read the literature, it's referred to as Andexanet or Andexanet alpha in most of the literature. But yet now, the FDA did not allow Andexanet as its title, and we have to call it, let's see if I can do this right, coagulation factor 10A recombinant inactivated ZOZO, or ZHZO. Whoever can tell me what ZHZO is can have all my dessert. No, but you cannot tell me what ZHZO is because I think you know. But what, you guys have any idea what ZHZO stands for, Colin?
You know, until you clued me in on this, I asked Dr. Google and Dr. Uptadate and all of those online resources, and nobody really had any answer. I had no idea.
Do you guys know what ZHZO is from? So Andexxa is a recombinant DNA protein. It's a biologic. And so whenever you're making a biologic, the patent is eventually going to run out on this agent. And so somebody else is going to be able to manufacture it. And if they can manufacture it within 95% of what Andexanet is, then they can call it Andexxa as well, or Andexanet as well. But there's a 4-letter suffix at the end of it that's randomly generated so that you can tell who's manufacturing this. And they got lucky with ZHZO. They could have been unlucky, and it could have been SH something, I don't know. But ZHZO is really totally random. And if you Google it like I did, or like Colin did, you're not going to come up with an answer. It's totally random. So we call it Andexxa now.
Maybe we should make a Wikipedia page about that.
There you go. So Andexanet alpha, I can call it Andexanet alpha because this is a CME talk. This is actually a beautiful protein, and I like this slide because it's quite helpful. If you look at the orange colored molecule, that's native factor 10A. The purple one is Andexanet alpha, and it's a recombinant inactive factor 10A decoy protein. What does that mean? So it's structurally similar to what we see with native 10A. You can see actually that it's missing one part right there. That's the binding site on native 10A, and this is the binding site on Andexanet. The difference is the binding site on Andexanet is not catalytically active, so you don't have any anticoagulation. What it's doing is it's binding all the 10A molecules, the anti-10A molecules in circulation, so Rivaroxaban, Apixaban, Idarucizumab, even enoxaparin, it's binding them and it's sequestering them so that they're not binding to native factor 10A, and you allow the coagulation cascade to exert its effect. The other thing is it's missing this little appendage there. That's a really interesting and important appendage. It's a glutamic acid subgroup. And what happens is when Colin showed 5 and 10 kind of come together, they form this prothrombinase complex. That prothrombinase complex, through this little appendage there, that glutamic acid subgroup, that's what binds to the platelet and causes thrombin to be released. And you notice Andexanet does not have that. So it is not thrombogenic. So there's a huge misconception by some people that think that the medication is thrombogenic. There's no prothrombosis with Andexanet alpha at all. So its main mechanism of action is by sequestering and binding Rivaroxaban, Apixaban, all those anti-10A molecules in circulation. And there is a mechanism of action where it actually binds tissue factor pathway inhibitor, which is a negative feedback loop back to factor 7. And by inactivating that, it allows the factor 7 thrombin generation to also occur. Beautiful setup. So this is the Annexa-4 study. Annexa-4 has been published. The Annexa-4 trial itself has been completed, but all of the analysis has not been done yet. So if you are 18 years of age or older with a major bleed, and your last dose of anticoagulant, and in this study, it was one of 4 anticoagulants. I'm still trying to figure out, is Annexa-4 because it was a phase 4 trial, or is it Annexa-4 because there were 4 drugs that were studied? The 4 drugs that were studied were Rivaroxaban, Xarelto, Apixaban, Eliquis, Idarucizumab, Severity, and enoxaparin, Lovenox. So it was a phase 3-4 trial. 18 years of age or older, your last dose within 18 hours, and you have a major bleed. You're given Andexanet alpha at a bolus, followed by a 2-hour infusion, and then you're assessed for change in anti-10A level as well as clinical hemostasis. And you're assessed at 1 hour, actually at the end of the bolus, at the end of the infusion, 1 hour, 4 hour, 8 hour, 12 hours highlighted in red because that's when they assess for hemostatic efficacy. And then again at day 3 and day 30 with safety measures as well, looking for thromboembolic events as well as antibodies because it's a recombinant decoy protein and 30-day mortality. So Anticoagulant dose selection, there's 2 different doses, and there's some confusion over this. It's really not that confusing at all. If your last dose was within 7 hours in the study, so patients on Apixaban or Rivaroxaban greater than 7 hours received the standard dose of 400 milligram bolus plus 4 milligrams per minute as an infusion for 2 hours. If they were on Rivaroxaban greater than 7 hours or on enoxaparin or Anticoagulant, they received double that dose, which is 800 milligram load plus 8 milligrams per minute. Nothing that we have to memorize right now. If you look at the baseline characteristics, now patients that received any Andexanet were studied for safety. Efficacy, you'll see that the N is somewhat smaller because later an independent adjudication committee had to decide whether or not it met criteria for a major bleed and also whether or not patients that were on enoxaparin had clinically appropriate anti-10A levels on board. And you can see that the characteristics are fairly balanced along both safety populations as well as efficacy populations. No major differences between the 2 groups right there. You can see that most patients had some degree of comorbidities, whether it's MI, stroke, heart failure, or diabetes. A lot of the things that you talked about that increases the patient's predisposition to bleeding. The site of initial bleeding, most of the time we're seeing intracranial hemorrhage. Patients had a mean Glasgow Coma score of about 13.9, 14, and you can see the distribution of the intracranial sites. And then GI bleeding about 30% between efficacy and safety population, and other bleeding about 12% respectively. So this is a little bit of an interesting slide. This is data from the Anticoagulant trial itself. On the y-axis, we're looking at anti-10A levels. And you can, the chart on the top left is Rivaroxaban, on the top right is Apixaban. And one thing you can notice is that the initial dose, actually the level of anti-10A on board on patients taking Rivaroxaban was slightly higher than those that were taking Apixaban. You know, most of us think that probably patients that are on Xarelto have higher levels of anti-10A on board than patients that are taking Apixaban. And that's exactly what we saw here, a mean dose of about 169 level, and then baseline level for Apixaban is about 132. And then you give the bolus, and you see the anti-10A levels come down fairly quickly. And then around the 4-hour mark, they start to come back to equilibrium. But you had about a 90% reduction in anti-10A levels within 2 minutes of giving the medication. And the next graph will actually go through this. Similarly, with enoxaparin, we saw a pretty drastic reduction in anti-10A levels within a couple of minutes of the patients receiving the Andexanet. So this is based on healthy volunteers, actually. The first graph I showed you were patients in the Anticoagulant trial. This is patients on Andexa-R, and you could see they had a mean anti-10A level of about 300 nanograms per ml. Patients were either given placebo, and that's the top line, or they were given Andexanet, and within 2 minutes, you had almost a 90% reduction in anti-10A level. That was followed by about a 2-hour infusion, and then I turn off the infusion, and anti-10A levels kind of come back up. So that 2-hour time frame was picked intentionally to ensure that there was adequate time for hemostasis to take effect. You'd think after reversing the anticoagulation for about 2 hours, you'd get adequate hemostasis. So this is what we saw in Rivaroxaban. We see a very comparable finding also with Apixaban. You notice that the initial anti-10A levels were a little bit lower at 200 nanograms per ml. But again, you give the reversal agent, and within 2 minutes, you've got about a 90% reduction in anti-10A levels. It sustains that with a 2-hour infusion. Turn it off, 2 hours later, your anti-10A levels come back up to baseline. When we looked at measuring effective hemostasis at 12 hours post-Andexanet, About 83% of the patients achieved was categorized as excellent or good hemostasis. Now, there are some studies with PCC that have similar findings, some a little bit less. We'll go over some of those in a little bit and discuss, because the trials are not identical. But there are some trials with PCC that show hemostasis of good and excellent of about 83, 84% as well. So this is the mean trend line, and if we look on the left-hand side, this is subgroup analysis, and it's not intended for us to draw any kind of statistical significance here, but if you look at the mean trend line, whether it's they were on Apixaban, Rivaroxaban, whether they were male or female, the site of bleeding, the age, whether they received the low or high dose, you can see the trend line had somewhere between 80 and 93% for excellent or good hemostasis, with the confidence interval in parentheses. So all in all, pretty good overall hemostasis, good or excellent about 83% of the times. From a safety perspective, here's the big question. Does Andexanet make you thrombotic? Does the drug itself, is it prothrombotic? It does not make you prothrombotic. So we did see some patients experiencing some thromboembolic events. Within 3 days, there were 6 patients that experienced it, and by day 30, about 11% of the patients had it. What this means is that patients who were on an anticoagulant are predisposed to having thromboembolic events. Much the same way you would see boxed warnings on patients with Xarelto or Eliquis that says premature discontinuation of this medication will increase your risk of thrombosis. Well, similarly, if I reverse that or take away that protective anticoagulant effect, your risk of thrombosis occurs. In 145 healthy volunteers in the Annexa-R and Annexa-A trial, 0 patients out of 145 saw a thrombotic event when you gave them Andexanet. So the medication is not prothrombotic at all. When we reinitiate anticoagulation, 129 patients had anticoagulation reinitiated by day 30, 57%. However, and I'm glad we don't have to decide this, only 9 of those patients received therapeutic anticoagulation dose. So the big question is, when are you going to reinitiate anticoagulation? This is kind of that teeter-totter that Colin had showed earlier. We can cause bleeding, we can cause thrombosis. When do we reinitiate anticoagulation to prevent thromboembolic events from occurring? So actually, one of my colleagues who was a principal investigator in this trial asked me to ask you guys this question. When would you feel comfortable with reinitiating anticoagulation? I mean, I know as ER docs we don't have to do that, so that's the beauty. But when do you reinitiate anticoagulation? Because the longer they're not anticoagulated, the longer that patient's predisposed and at increased risk for thromboembolic events. Let's just say a patient has an intracranial bleed. You've given them Andexanet, you've reversed it. Would anybody feel comfortable starting full dose anticoagulation? Because this patient's a CHA2DS2-VASc 8. I mean, it's got to be case-by-case basis that patient has an LVAD, and you're going to get you have to restart it. Otherwise, therein lies some serious trouble ahead. All right, hey, discussion. Colin, you sort of talked over this. What was the intracranial hemorrhage mortality rates in the large atrial fibrillation trials? I know you know this because you said it. Do you guys remember what the intracranial hemorrhage mortality rate were in Rocket AF and in Aristotle? I'm sorry, what was that?
Almost 50.
Yeah, it was slightly under 50%. So about 48% and 45%, if I recall. 48% for Rivaroxaban, 45% for Apixaban. So almost 50-50. So Colin, do you think reversal improves the morbidity and mortality if we gave them Andexanet?
That's what seems to be shown by the initial kind of a drop-in or look into the studies. And again, the final answer in Annexa 4 has not been published yet, but what we see now is a significantly reduced mortality, somewhere down close to 14%.
So, I mean, these weren't apples to apples comparisons, but it was pretty significant that we think that Andexanet probably makes a difference. At least intracranial hemorrhage mortality rate from 45 and 48% down to as low as 14%. Again, difficult to make a cross-study comparison, but pretty significant dramatic decrease. Study populations were no doubt different. So Idarucizumab, this is a cool name. This is Proxbind. I dare you to
By
say
the way,
it.
the UMAB is Latin for complicated and expensive? No.
It's actually neither. It's no more expensive than PCC, and it's a beautiful drug. It's a monoclonal antibody. It's kind of like Digibind is for digoxin. It's got the affinity for Pradaxa about 350 times more than native factor 2 does. So it goes in there and it binds all this, and it brings your thrombin time down almost instantly. It's also very rapidly active. This is the drug of choice for patients that have life-threatening bleeds on dabigatran. What about non-specific hemostatic agents? There's hemostatic factors have been studied in patients. Non-specific for DOAC reversal agents, including PCC, activated PCC, recombinant factor 7, FFP. Currently, it seems, and that's why I was interested when you guys answered that one question. It seems that mostly PCC is what's being used if Andexanet is not available. That seems to be the old standard of care, if we call it that. According to the new CHEST guidelines, it's unclear whether normalizing coagulation parameters in healthy volunteers translates to improved outcomes in patients who are actively bleeding. So there were not that many studies on using PCC in patients that were actively bleeding. The initial stuff was actually in healthy volunteers. And there are, well, here's PCC. It's a mix of non-activated clotting factors. There's two types. There's 3 factors and 4 factors. The Profil 9 is the 2, 7, and 10, and Kcentra or Octaplex is the 4-factor PCC. So these are some early trials in healthy volunteers looking at either Rivaroxaban or Anticoagulant, or again Rivaroxaban, in whether or not cofactors or PCC will reverse. And by reverse, we're talking about how they were measured here, usually PT, or thrombin generation. So the first study by Ehrenberg in 2011 looked at relatively healthy volunteers, 6 patients. They were on Rivaroxaban, and they were on pretty decent doses. And if you gave them clotting cofactors, you were able to bring their PT time back low. And their thrombin generation time, not so much. So that's maybe suggestive that it's beneficial. You look at the next trial. This was on Andexiban. Again, looking at PT and thrombin generation. They also looked at actually bleeding duration following punch biopsy. So they were able to bring the PT time down, not so much difference in thrombin generation, but no difference in affecting the bleeding duration with the punch biopsy. So maybe mixed results. The measure that we would ideally like to see is actually bleeding duration decrease. And then in the Levy trial, again, not that many patients, healthy volunteers. They also looked at whether or not you can bring PT or PTT or anti-10A levels. Now this is an anti-10A. Ideally what we want to see is anti-10A levels go back up, and there is no impact whatsoever on anti-10A. These are the healthy volunteers. What about what we see? Oh, and this is also a study by Sonny Zeke. They took healthy volunteers and they gave them Rivaroxaban. And they gave them, I think, 20 milligrams a day for 4 days. And then they said, okay, what happens if we give them 4-factor PCC and we give them saline? If Kcentra is going to work, it should cause anti-10A levels to go down. And you can see that the graphs are basically superimposed on one another. The red one being Kcentra, the gray one being saline, no significant impact. So we're getting mixed results with Kcentra. If we actually look at trials that looked at patients with bleeding, these are a little bit more interesting. Gerner in 2018, this was recent, right? This is in Germany. 146 intracranial hemorrhage patients, 131 of them on an anti-10A and 15 of them on Pradaxa. Primary efficacy endpoint was hematoma enlargement. Secondary efficacy endpoint was mortality and functional status. The results, no change in hematoma expansion with or without PCC. 30-day mortality rate, remember the previous trials with Rocket AF and Aristotle had about 45 and 48% mortality rate. Here we have a 30% mortality rate with or without PCC, no change. but it was a 30% mortality rate. Again, significantly higher than 14% in what we see preliminary data with the Anticoagulant trial. 33% had a favorable modified Rankin score. With or without PCC, did not make a difference. So as far as neurological outcome, PCC did not make a difference. So that study, kind of negative on bleeding patients. The Schulman trial, this was out of Canada, 66 patients on Riva or Apixaban. This was a prospective cohort trial looking at primary hemostatic effectiveness. 85% effective hemostasis. That sounds very promising until you dig a little bit deeper into the trial and you realize that the time from their last anti-10A dose until they received PCC was a median time of 18 hours with a standard deviation of 10 hours. In the Anticoagulant trial, if your last dose was more than 18 hours, it was an exclusion criteria. And that's because the half-life of these medications are fairly short. So I know we have pharmacy in the room. Well, what do you guys think the half-life of these medications, of these anti-10As are? Let's exclude Apixaban for now. Andoxaban, Apixaban, or Rivaroxaban's half-life. It's only about 10, 11 hours in relatively healthy patients. By healthy, I mean normal renal function. So if your last dose was more than 18 hours ago, you don't have a lot of anti-10A on board. So with a median time of 18 hours plus 10 hours, you're not expecting to see a lot of morbidity and mortality in that patient population by giving them hematoma expansion or hemostatic effectiveness. The anti-10A level is almost back to normal. Majid, 2017, 84 patients on Rivaroxaban or Apixaban. Again, primary efficacy endpoint was hemostatic effectiveness. 69% hemostatic effectiveness, 31% no. Intracranial hemorrhage mortality rate, 34%. So now we're seeing in some larger studies, 30% intracranial hemorrhage mortality dose. This one, the last dose was within 24 hours, but the median time was 12.5 hours. So a little bit better of a trial design than the Schulman study. So this is complicated, you guys. There is no head-to-head comparison on this stuff. So what do we do besides assess each patient on a case-by-case basis? I would get rid of maybe in the next time I look at the slide deck. The answer is there is no easy answer. But it appears that Andexa or Andexanet or Andexanet alpha or ZHZO is probably a better agent. I mean, there's no probably. It's a reversal. Giving them PCC is replenishing their factors. Giving them Andexanet is actually reversing by sequestering Rivaroxaban, Apixaban, the 10As that are in circulation. Final answer with the big guns. PCC 3 and 4 factors, they work well on warfarin. It makes sense. Rivaroxaban, Apixaban, Andoxaban, Apixaban is not reversed with PCC or activated PCC replenishing agents. But Andexanet will reverse anti-10A levels and improves bleeding. Dabigatran, I don't really care if it's reversed by PCC. The drug of choice is going to be Apixaban or Idarucizumab. The coagulation and anticoagulation are very tightly and carefully maintained. There is a balance. For every activator, there's a deactivator. We can force people to clot or bleed. We can make that teeter-totter. We can push down on one side or push down on the other side. The question is, what should we do and how do we balance the risks? And quite honestly, I mean, we're going to do no harm when we can. And thank God we're not the ones that have to decide when they're anticoagulated. So how do you guys feel about the interpretation? Colin, what do you think about the interpretation from either Apixaban or Andexanet?
I think the data is pretty good to tell us that these things work and they do what they're supposed to do. What we need and is coming now that the drug is available, we're going to start to see a lot more studies done. But what we've seen so far has been very positive, and enough to say we don't have a really good answer other than this, and this is where we need to be going at this time.
I'm going to change the second bullet point on the fly. I know this is a CME talk, but I was at a talk yesterday where I heard some misperceptions, and I think that misperceptions need to be sort of corrected. We talked about what patients should be reversed. Some of the apprehension I've seen in wanting to use Andexa even though people think it might work, is cost. So even though this is a CME lecture, I want to talk about cost for a second. There's a huge misperception on this. It costs $58,000. It costs, $25,000. Well, sort of. It does cost about $24,000, but as of October 1, there's this thing called NTAP, which is a new technology add-on payment, which allows you to be reimbursed an additional $14,000 on top of your DRG reimbursement. So it brings your cost down to about $11,000. Now I want you to put that in perspective of what you're paying for PCC. And I want you to put it in perspective of intracranial hemorrhage mortality rate being decreased and length of time in the ICU being decreased by about a day and a half. So net, you're budget neutral using a much better drug. Question then is, how do we best get these agents on formulary, and do you want it on formulary? Do you guys have it?
We do not have it yet. We are having our meeting in order to make our final decision probably within the next couple of weeks. And if I'm talking to people, we know where it's going to go. But the problem is you kind of have to, you really have to get these people on board, make sure that when the discussion happens, that they do get a chance to look at all the data and to understand that there are good reasons why PCCs don't replace something like this.
We also don't have it on formulary. I'm part of a large health system that wants a common formulary, but I also think that there's some misperceptions. They look at the data with PCC and they say, hey, you've got 85% good or excellent hemostasis, but they don't pay attention that the median time between dose and PCC is 18 hours with a standard deviation of 10 hours. And they look at the sticker shock of, it's $25,000 or it's $50,000. No, it's not. It's really going to cost you a lot less. So there's definite need for education. I think now that American Society of Cardiology, American Society of Hematology, CHEST, soon ASAP, will have their guideline recommendations that are suggesting specific reversal agent. It's going to be difficult for respectable institutions, level 1 trauma centers, comprehensive stroke centers, not to have this as a therapeutic option when life-threatening bleed is certainly prevalent. Now that we have specific reversal agents, where and when should we use PCC? I think that one's almost self-evident. If you don't have Andexa, you should use PCC. Just realize it doesn't work as well. But are there other times we should use PCC? I agree.
In warfarin.
In warfarin.